summarizes, immunology greatest hits type of thing that would introduce the subsequent lecture. So I guess it's still there. So you can read it as a help, okay? It's not going to be on the exam, but you can read it as an overview of immunology. The second thing is this lecture, I added a few more slides, and I gave the presentation to the micro department who will post it online, okay? So if you printed this lecture out, you will see there's a few slides that are not in your printout, but they will be on UB Learns, okay? All right, so this is a first lecture among 3 topics on basically what can go wrong with an immune response. Now, there's 3 very simple things that can go wrong with an immune response. The first one and most obvious one is that either part of it or the whole thing doesn't work, okay? And that is immunodeficiency, and we'll cover that in a different lecture. The second thing that can go wrong with an immune system is that it works fine, but kind of sees you as the enemy, okay? It's kind of lost the perception of what is you and what is not you, and therefore reacts against you, and that's autoimmunity, and we'll cover that. And then there's a big overlap between autoimmunity and hypersensitivity, simply because most hypersensitivity reactions are autoimmune reactions. And hypersensitivity, the third thing that can go wrong, is that your immune system works well. The immune system can recognize a foreign entity, but the weapons that it uses to protect you are more damaging to you than the threat itself, okay? Let me give you a silly analogy. Let's say that I'm a bodyguard, and I am hired to protect her from any potential threat. Now remember, I don't know what's good or bad for her, just what belongs and doesn't belong. So I'm sitting here watching her, make sure that she's safe, and a fly comes around and lands on her forehead. Okay? I'm not implying that you attract flies, it's just an example. Okay? So I see, it doesn't belong, could be a potential threat. So I take a shotgun and I blow the fly away. Okay? Don't laugh. I mean, it's a silly analogy. Don't laugh, because there are certain situations, we'll talk about systemic anaphylaxis, where you could have somebody die on you. Okay? So it's not that far from the truth. Now, obviously, you must agree, even though this is a silly analogy, that the action that I take to protect her are much more damaging to her than a harmless fly. Now, hypersensitivity works in the same way, where the immune system is the bad guy. Okay? The immune system is the one that creates problems. In most cases, these problems are not that severe, okay? But in some, they are. So hypersensitivity basically is immune reactions that are overly injurious to the host, meaning that the immune reactions are the one that cause the damage. Okay? Now, a very important point, because you may not think of this, they occur in subjects that have been previously exposed to a particular antigen, in this case an allergen, okay, and who have developed an immune response to that particular antigen or allergen via a process called sensitization. Now, the clinical manifestation, what you feel, okay, is not so much the result of the specific antigen, but rather of the host's response to the antigen. How your immune system responds determines what kind of clinical conditions you experience. And this can occur pretty much anatomically anywhere, okay? For example, upper respiratory tract, where you get hay fever, or lower respiratory tract, where you get asthma, GI tract, skin, contadermatitis, okay? And the bad one, generalized anaphylaxis, okay? So, that banana that you get a Harriman could be really bad for you, okay? No, banana is not a common allergen, but just to say food can also be bad. And most allergens are inhaled. No, that's not me. That's not me, but a friend of mine sent me one of these, so I thought it was funny. Anyway, it's a big kid. Very common allergen. You know what they are? Dust mites. Yes, dust mites, okay? I don't care how clean you are, you have them. They live in your bed, they eat off shed skin, and typically, it's lunchtime now, the allergen is fecal matter from the dust mites, okay? It's a very common allergen. Now, allergens are very, very common in many, many ways. Okay, no, that's not on, this is one of the slides. Those blue slides are not going to be there, okay? Just listen to me. So it could be anything from dust to pollen to animal dander, food, various medication, certain metals, okay? For instance, with contact dermatitis, for instance, nickel, component of certain cosmetics, and then venom of certain stinging insects. Okay, these are all common allergens, meaning antigens that it can elicit a hypersensitivity reaction. Now, hypersensitivity reactions are divided into 4 types, cleverly labeled 1, 2, 3, and 4. And this definition is based upon the timing and the mechanism by which these reactions occur. So type 1 is called also immediate hypersensitivity. It's one of the most common types of hypersensitivity. And it's called immediate because it is compared to other one, especially type 4, which is called delayed hypersensitivity, because they compare the timing between exposure to the allergen and hypersensitivity reaction. So in here, you react very quickly to an allergen. In here, it takes some time to react to an antigen. So these are just to show you the timing involved between exposure and reaction, okay, typical timing. So obviously this is much faster than this one. Now, type 1 hypersensitivity, I'll summarize the 4 and then go into details. It's also called immediate hypersensitivity. It is associated with what was classically we call allergic reaction, anaphylactic reaction, and is mediated by IgE. Okay, remember when we talked about the immunoglobulin classes, IgG, IgM, IgE, IgD, and IgA, IgE was the culprit in allergic reaction. Okay, now, the clinical manifestation of type 1 hypersensitivity, what you feel and what happens to you, is basically due to a bunch of chemicals that allergic cells such as mast cells and basophil released upon activation. Okay, now it's really kind of unclear. There are some theories why certain allergens stimulate an IgE, specifically an IgE response. Okay, partly is due to the fact that IgE, Mother Nature has designed IgE and these cells that get activated, is to fight parasites, you know, things that burrow into your mucus, worms, things like that. And because certain allergens, but not all of them, certain allergens, okay, mimic some of the chemicals that are used by parasite to attack you, sometimes the immune system thinks that you are attacked by a parasite, even though it's not, and reacts to that particular chemical that are released by a particular allergen. So the clinical manifestation, once again, are due, and I'll talk about these mediators, that are released by allergic cells that have been stimulated by an allergen. Now, the whole idea of all these chemical mediators is to create pharmacological and physiological response that eventually are designed to do various different things. For instance, by clearing the gastrointestinal tract by vomiting or diarrhea, okay, because something is perceived to be attacking your GI, you want to eliminate it, okay, you want to throw it out or you want to defecate it out. Or by blocking airways, okay, meaning trying to keep stuff from getting in. Or by increasing fluids and blood flow, for instance, altering capillary permeability so that the cells that are designed to combat this perceived threat can get into the tissue and attack that threat. So all these are designed by Mother Nature to protect you, okay? Unfortunately, in the long run, it don't, okay? But that's the design of the whole system. Now, the other thing that you may think of is that when you have an allergic reaction, okay, the first thing you can think of is, this is something that I've just encountered for the first time. That's why I'm allergic to it. Okay, I've never seen it before. That's really not the case. Okay, in other words, most of allergic reaction of hypersensitivity are caused by subsequent exposure to an allergen. Okay, When the allergen first comes in, you have a sensitization state, okay? And you may not have physiological responses, but the second time or the subsequent time the antigen comes in, now you do. Okay? So what happens? What happens is that upon first exposure to an allergen, the body reacts by producing IgE. Now, this IgE does what? These IgE that are specific to the antigen bind to mast cells and basophils, which have receptors for the Fc portion of this IgE. So now these mast cells become almost like, old-fashioned mines with IgE specific to an allergen sticking out, and they are armed. Okay, so now you have a mast cell or a basophil that has IgE specific to a particular allergen created by the first presence of the antigen stuck on the surface. Okay? Now, what happened, once bound, then the IgE remains on the surface of the cell. So now the cell becomes what is called armed. It has these IgE molecules sticking out. If that allergen then comes from a second time, what happens? What happens is that these sticking out IgEs from the allergic cell get cross-linked and activate the cell. And this is where you have the physiological response. Okay? And this is basically what I just said. Now, this in turn causes a double whammy of response of an allergic reaction when you have an early phase and a late phase. And each of the phases are characterized by a wave of different components that create different physiological responses. So the first one, once you have this armed basophil or mast cell that is activated by the antigen, the cell degranulates, okay, releases into the environment stuff that it keeps in bags and granules within the cell. And these particular stuff has some early phase physiological responses, okay? And these are the early phase responses: histamines, prostaglandins, chemotaxins, and various. This is why you take antihistamines, by the way. Then there is a later phase in which there is further activation. There is secretion of various different cytokines, which in turn exacerbate the response, okay, and continue on and sometimes have chronic responses, just like in chronic asthma, okay? But most of the severe clinical manifestation are usually due to the early phase response, if you get an asthma attack. So here is a mast cell that is coated with IgE. I only show two of them, but imagine that these guys are sticking out everywhere, okay? Here is an allergen that comes in. This IgE was created when this first guy came in the picture, okay? Now it comes in for the second time and cross-links two of these IgE components stuck on the cell, and the cell now gets activated and degranulates. And what it does, it releases preformed mediators, mediators that are already made and stored in a bag within a cell. Now, the second phase is that furthermore, now there is a further activation of the cell, cytokines are released, and now you have various different other newly synthesized mediators that the cell makes anew and continues to release. Okay, so what are examples of preformed mediators? So once the cell gets activated by this allergen, it degranulates. It releases these chemicals from granules within the cell. And these are examples: histamines, eosinophil chemotactic factors, serotonin, proteases, etc. And what do they do? What do they do is they create situation to allow the immune response to work better against that allergen. For example, it causes capillary permeability. By changing the permeability, it allows cells from the bloodstream to get into the tissue where the perceived threat is found. And or smooth muscle contraction. For example, it constricts your respiratory system to keep things out, to prevent entry from this perceived enemy. Okay, and there's a whole bunch of different that have various different functions. Recruitment of neutrophils. Okay, so all this in the first wave of preformed mediator release create all kinds of pharmacological and subsequently physiological responses. And here are newly synthesized mediators. Now these are made anew, for instance, leukotrienes, platelet active active factors, some prostaglandins, various different cytokines, and all these further exacerbate the response. Once again, capillary permeability, constriction of bronchi, smooth muscle, platelet aggregation, all these create the physiological responses that you may get in a particular type 1 hypersensitivity reaction. Okay, so here is an antigen, okay, release of IgE. IgE binds to the mast cells. Okay, now a second time the antigen comes in, cross-links 2 or more of these receptors, and the mast cells now degranulates various different things, as well as makes some new ones. These are the clinical effects. Now, the bad one is systemic anaphylaxis. Type 1 hypersensitivity, in most cases, is resolved as a localized reaction. I'll show you some pictures of it in a minute. Okay? For instance, hay fever, asthma, atopic dermatitis. Okay? All these are localized anaphylactic reaction. However, in rare cases, what you could have a systemic anaphylaxis where you have a massive response to a particular antigen. Okay, so you have massive capillary permeability increase, which does what? That lowers blood pressure. Okay, so you could have a drastic result in blood pressure as well as respiratory arrest. In other words, complete shutdown of your respiratory system in an extreme case of the immune system trying to protect you from some perceived enemy, which may or may necessarily not be an enemy, but in turn causing all kinds of really severe, severe airway obstruction or loss of blood pressure. Okay. Now, what can cause systemic anaphylaxis? There's a whole bunch of different allergens that are known to be propense to make a systemic anaphylaxis response. Venom for certain bees or wasps. If you ever heard of the story, this guy got killed stung by a bee. How can that be? This is what happens. Food products, peanuts, for example. Okay, sometimes schools send out a flyer. There's a child is allergic to peanuts. Please be careful what you bring in school, because that's a life-threatening situation. Penicillin. And others, okay? So there are various different allergens that can cause systemic anaphylaxis. Most cases are localized. This is a picture of a localized atopic dermatitis. And here is a picture of localized anaphylaxis to a bee sting, okay? Obviously, this lady has an issue, okay? And this is the immune response that does more damage to the lady than a particular bee sting. Okay. Now, what is a very, very common type 1 hypersensitivity, especially around this area? Asthma. Asthma, which is characterized, obviously, by, thankfully, in most cases, reversible airway obstruction that is due to an exaggerated airway responsive to various different stimuli. Now, it can be an antigen, sometimes it can be a physiological stimuli. But this is usually, okay, well, I'm talking about allergic asthma, okay, and this is a distribution of atopic asthma in various different groups. So once again, there's an early phase, like in any other anaphylactic reaction, and a late phase. Okay, so you have an early response, you have smooth muscle contraction, vascular leakage, mucus secretion, and then a late phase response where you have recruitment of other other allergic cells, as well as neutrophils, infiltration of macrophages, fibroblasts, Okay, so here is the activated mast cell in asthma. You have degranulation, release of various different mediators, an early reaction, and then you have a late phase reaction, you know, the biphasic response typical of type 1 hypersensitivity. So basically what happens is that all these mediators in asthma then cause a physiological response which results in the swelling of bronchial mucosa, in the spasm of the muscle of your respiratory system, and on top of that, in production of mucus plugging the bronchial lumen. And what happens? What happens if you have the swelling of your bronchi, okay, mucus, and the constriction of the muscle of the bronchial system? You have the typical, you know, that wheezing that you hear from a classical asthma patient. And here is just a picture of the same thing when you have mediators release, either preform or later on secreted, and basically what you have is the overall construction and inflammation resulting in airway restriction. Now, the key is, why is it that some antigens are allergenic? Okay, what makes an allergen allergenic? Once again, usually they tend to be very small proteins, okay, that are present in certain dry particles, for example, dust or pollen. And what happens is when they get into your respiratory system, they get wet by the mucus in your respiratory system. And what happens is they release these proteins, they become soluble and get into your system. And some of these components, for sometimes for reasons unknown, tend to stimulate an IgE response. Okay, so once again, the theory is because IgE responses are usually generated against various parasites, it is thought that some of these proteins that are released by these allergens may mimic what the body thinks is a protein used by a parasite to attack you, and therefore an IgE response. Okay, now this is not the case with all of them, so sometimes the reason is unknown. So how do you test for type 1 hypersensitivity? You really basically test for two things. Okay, either you test the components of the immune system against a particular allergen, or you test the reaction of an individual to a particular allergen. Okay, so early tests were called radioimmunosorbent test, okay, and radioallergosorbent test. Okay, the radioimmunosorbent test is now being replaced by enzyme methods, by colorimetric methods, but the principle is the same. The RIST measures total level of IgE. You're asking the question, how much IgE does this individual have in its bloodstream? IgE to any allergen, doesn't matter what, okay? And if the IgE is elevated compared to normal values, then you start thinking about an allergic reaction. And the other one is you measure IgE specific to a particular antigen. Okay, so in this case, the RAST measures IgE specific to allergen X. Okay, so the RIST and RAST are measurements of your immune components, either in total or against a particular allergen. Now, what happens more often is skin testing, where you actually test the response of an individual to a particular antigen, okay, to a particular allergen. So what happens is you are evaluating the in vivo response. And the advantage is it's very simple and very sensitive. So basically what you do is you have what is called, the first one is called a prick test, where you actually prick the skin with a particular amount of allergen, okay, and then you wait for the reaction. So you have a negative control with nothing but saline, and of course that shouldn't be a react. And then you have a positive control where you actually prick the individual with a little bit of histamine, and that should show you that the test is working. And then you test different allergens. And do I have a picture of that? No. So the second test is what is called an intradermal test. Instead of pricking the skin, you actually inject a little bit of the allergen underneath the skin, okay? But you have to be very, very careful in this case, because if the person is highly allergic to something, you don't want to create an anaphylactic reaction. But anyway, this is the typical prick test where you have, here is histamine control. Okay, you see a reaction here. And here is the negative control. There's no reaction. And there's a various degrees of response to, I don't know what these allergens are, but just to give you an idea that obviously this person is allergic to this particular allergen. Okay? And this is very simply done in an office. Now, why is it that certain people are allergic? How come I'm allergic and you're not? Well, there's various different theories, okay? But there is a bit of genetic association, okay? First of all, it depends whether that individual is more likely to develop what is called a Th2 response. Helper T cells, when precursors, can develop into what's called Th1 or Th2 responses. The Th1 tends to create more of a cell-mediated immune response, where a Th2 tends to create more of an antibody immune response. So if you are Th2 type of guy, you're more likely to develop an antibody response to an antigen. And this is the story. So you have Th1, which develops more of a cell-mediated response, such as delayed type hypersensitivity, or Th2, which is likely more to develop IgE. So the Th2 type of person who is more genetically propense to produce a Th2 type response is more likely to produce IgE against an allergen versus a cell-mediated immune response, and therefore is more likely to develop a hypersensitivity reaction to that antigen. Okay? So I'm going to skip these two. Okay? So the bottom line is, chances are, if you have family members who are allergic, you're more likely to also be allergic to that particular allergen. Okay? And in fact, when a child has a family has a CRP allergy, people want to test all children in that particular family because of the genetic component of type 1 hypersensitivity. Now, how do you treat? Well, the simplest thing, of course, is avoidance. Okay? I mean, simply enough, if you're allergic to cats, don't get a damn cat. Okay? However, unfortunately, this is not so easy because many times these allergens are ubiquitous. You can get away from cats, but you can't get away from pollen or from dust. Okay? So the other thing is downregulation of inflammatory process, relief of symptoms, of course, and sometimes hyposensitization. Hyposensitization simply means in very severe cases, what they do is they take the allergic individual in a very controlled clinical setting, make sure that this person doesn't get a very strong reaction, and administer extremely, extremely minute amounts of that allergen, okay, over and over and over for a long period of time, months. Okay? Well, somehow, I don't really understand the mechanism myself, this long-term exposure to very, 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 very small amounts of that allergen somehow switches the antibody response from an IgE response to an IgG response. And IgG does not cause the degranulation of mast cells and all the other stuff that creates a hypersensitivity reaction in the individual. All right, so type 2 is basically an antibody-mediated process where you have an antigen or an allergen that somehow is deposited onto a particular surface, okay, and that surface now is seen as an enemy. IgM and IgG are produced against that allergen that somehow is deposited onto your surface, and the production of IgG and IgM activate complement, and complement now destroys the tissue in which that antigen is particularly found on, okay? And the classic, do I have an example of this? Hemolytic anemias is a classical example. And hemolytic disease of the newborn, I'll show you this in a minute, okay? For example, there was a time in which many, many years ago in a textile industry, for some commercial reason, I don't know textiles, they used to use a lot of formaldehyde for whatever chemical reason. Well, formaldehyde is a compound that can change or fix the shape of proteins. And so only upon long-term exposure of formaldehyde by these textile workers, some of the surface components of red blood cells, some of the proteins, now became different looking. They were chemically altered. And what would happen? What would happen is that the body now sees these chemically altered proteins as foreign entity, okay? If your girlfriend or boyfriend comes back home and she has a third eye, you're going to blow her away, okay? Because this is weird, something's wrong, okay? So the point is that this immune response against this perceived foreign entity will cause what? Will cause the lysis of red blood cells. And of course, these workers would develop hemolytic anemias. Now, the most drastic type, and by the way, again, there's a lot of crossover between hypersensitivity and autoimmunity, of the type 2 is a condition called erythroblastoma fetalis, okay, or also called hemolytic disease of the newborn. You guys had blood groups at all? You know what blood groups are? Yes? No? Yes, okay. So basically, blood groups are entities on the surface of red blood cells. And very simply, if you have entity A, you're group A. If you have entity B, you're group B. If you have both, you're AB. If you have neither, you are O. Now, there's another series of blood groups belonging to the Rh system. And one of these components of the different Rh components is highly immunogenic, okay? So if you have this component, it's called the D component, okay, you're Rh positive. And if you don't have it, you're Rh negative. Simple enough. Now, what happens in erythroblastoma fetalis is that because of the genetic makeup of the father and the mother conceiving a child, you could have a situation if you have an Rh negative mother. The mother does not have that Rh component on her red blood cells, but because of the genetic makeup of the father, an Rh positive fetus. Okay? So what happens during the first childbirth, okay, first child, because of the mechanics of childbirth, some of the fetal red blood cells leak back through the placenta into the maternal circulation. Now, these cells have the Rh component from the baby. The mother's never seen this Rh because she's negative. So she sees this particular Rh component as if it was an enemy. This is foreign, doesn't belong. I've never seen it before. So she makes an antibody response to that Rh component because she's sensitized by the Rh positive cells leaking from the baby into the maternal circulation. Now, nothing happens to the first baby. Okay, the problem is that if you have a second or subsequent Rh positive child, now these antibodies, which tend to be of the IgG isotype, they can cross the placenta. Okay, they're designed to. This is how you get maternal immunity before you're born. Okay, they cross the placenta and they attack the the Rh positive baby's red blood cells. Okay, so here is an Rh negative mother with an Rh positive fetus. During the first childbirth, nothing happens to this baby, but now some of the fetal red blood cells, which are Rh positive, leak back into the mother and immunize the mother against this Rh component. The mother responds, makes all kinds of anti-Rh antibodies. They remain in circulation. Now, a second child, who happens to be Rh positive, now receives through the placenta these antibodies, and the antibodies destroy the baby's red blood cell. Okay? And this is this is just the same thing, okay? Okay, this is just the same thing that I just said. Now, this is a very devastating condition, okay? I show you a lot of funny pictures. This is not. Okay, this little girl has all kinds of problems. She has a huge splenomegaly. There's all kinds of different, the spleens try to get rid of all these broken red blood cells. You know, when you have a large amount of broken red blood cells, it's almost like a transfusion reaction. You have all kinds of other biochemical events that really affect, and you know, this is a pretty bad situation. So here is a situation where you have the immune system that is trying to protect you from something, doesn't protect you from something at all, and in fact harms your own baby. So what they do now is, if they know that the mother is Rh negative and the baby could be Rh positive, what they do is immediately after delivery, or even a little bit early, what happens is they give the mother antibodies against that Rh component, antibodies raised into another human, okay, against that Rh component. Now those antibodies, what they do is they destroy the few red blood cells that have leaked from the baby into the mother before they have a chance to immunize the mother against it. And this is called rhesus prophylaxis, okay, a product called RhoGAM, where once again you administer the Rh negative mother with antibodies that will destroy the few red blood cells that leak back from the baby into the mother, so those red blood cells don't have a chance to immunize the mother. Okay, and this is what it is. In other words, if you get rid of these red blood cells before they can immunize the mother, then you don't have the problem. Okay, then you have type 3 hypersensitivity, which involves the deposition of immune complexes. Once again, immune complexes are large groups, lattices, you know, chemical lattices of antigen and antibody stuck together to the point if they get big enough, they can precipitate out of solution, okay? And what happens is these immune complexes get deposited into things like big filters, lungs, kidneys, et cetera, okay? And what they do is, and by the way, many autoimmune diseases are also immune complexes diseases. Okay, we'll talk about that when we talk about lupus, when we talk about rheumatoid arthritis. So the body is trying to get rid of these immune complexes because that's its job. Unfortunately, what happens, once again, the immune system has more of a shotgun approach, more of a flamethrower approach, okay? So what happens is if these immune complexes get deposited into some area, the immune system basically flame throws that area, and in doing so not only gets rid of the immune complexes, but also the tissue on which they are deposited. And what is the classical example? Arthur's reaction, but more importantly, rheumatoid arthritis. Okay? Rheumatoid arthritis is caused by immune complexes that get deposited, in this case, in the cartilage of the joint, and there are cells such as neutrophils and other components of the immune system that are trying to chew up these particular immune complexes, but in doing so, they also destroy the cartilage that, you know, cushions the bone. And I'll show you a picture in the autoimmunity lecture where you have physiological and inflammatory responses that really do a lot of bone damage. And finally, you have type 4. Type 4 sensitivity is cell-mediated. Again, this is kind of a misnomer because, of course, all hypersensitivity is cell-mediated. Okay? But this really means the several different steps of the creation of antigen-sensitized helper T cells or cytotoxic T cells. Okay, and in turn, this takes much longer because you have to go through antigen processing and presentation, activation. Type 1 doesn't have to do that. You get the allergen, you get IgE on mast cells, the mast cell degranulate. This one, on the other hand, you have to have various different steps. You have to have an antigen presenting cell, you have to present the antigen to a T cell, you have to have a T cell response, release of cytokines, okay, and eventually you get a reaction. And the classical example is contact dermatitis or tuberculin reactions, okay, where you have an antigen or an allergen such as cosmetics or poison ivy is another classical example of type 4. Nickel from a watch band. You have formation of complexes with the skin. You have antigen processing and presentation, activation of a T cell, which in turn releases cytokines, and now these in turn go further and amplify the localized response to a particular allergen. Okay? Once again, what's a classical example? Contact dermatitis. Okay, they're usually caused by small substances. They get in contact with the skin, penetrate it, okay, and now are seen as foreign entities. Now, what are the example of some of these small compounds? Urshol on poison ivy or poison oak, or sometimes certain components of commonly used cosmetics, certain metals used in jewelry, for instance, nickel. Okay? So all of these can instigate a type 4 hypersensitivity, such as contact dermatitis. Okay, here's an example of a contact dermatitis reaction to the nickel in a watch band. This is just an enlargement of one of these, okay? As you can see, typical classical contact dermatitis. Here's an old picture, an example of the reaction to a garter belt rubber band. Okay, natural rubber has a lot of different allergens. I know that people don't use these garter belts anymore. She's laughing. She's thinking maybe something you guys in a light life or something like that. And of course, this can be quite extensive. Okay, this is an example of a lepromatous reaction in an individual, so it can really cover a big area. Now, one of the things that will be also important to you folks, and some allergies are particularly indicated to particular professions, and because all you guys, I assume, will be in some sort of health profession, medicine, dentistry, pharmacy, or whatever, okay, you're more likely to use latex glove, okay? Certain allergies are specific to certain professions, so you are more likely to wear latex glove for a long period of time in your career than if you are a librarian or an accordion player, okay? So chances are you're more likely to develop latex hypersensitivity. The reason is that latex, natural latex, contains a whole bunch of different allergenic proteins, okay? So what happens is that you get sensitized by long-term use, and eventually some of you may react. So the repeated exposure is primary risk factor. Okay, and obviously this, there's a higher risk among latex injury worker, people who make these gloves, as well as people who use them. Okay, this is the prevalence of latex allergy in the general population, but healthcare workers have a much higher prevalence of latex hypersensitivity. Once again, because certain hypersensitivity are specific to a particular profession. Okay. So how do you do this? Well, you don't have to wear a latex glove all the time, okay? You can just simply use vinyl gloves for a simple exam, for example, okay? Or sometimes you can use cotton or vinyl glove liners, Gore-Tex liners. I mean, you can get away with this. Now, so basically, hypersensitivity is basically immune reactions that are over-injurious to you. Now, the best thing to do is to avoid the allergen, okay? If you can do that, you can avoid the allergens, okay? But if you can, there are therapeutic approaches, most of which are symptom relief, okay? Now, we'll cover some of this stuff next lecture when we cover autoimmunity.